said, my name's John Young. I'm a geriatrician working in Bradford and currently seconded to NHS England as the National Clinical Director for Frail Elderly and Integration. And we're looking at frailty this morning, and we're going to be just looking at it in a slightly different way to the way it's usually conceived. We're going to try and conceptualise it as a long-term condition. And I've just put the first slide up for you, which is the voting slide, for you just to have a think about care and support planning, which is going to come into our story. And if you can just make some selections of those three simple questions. I'll give you a minute to do that just while I overtalk, because one of the key messages I wanted to explain to you was that when we're thinking about frailty, we're also thinking equally about that other large group of people that are difficult to manage in our system at the moment, i.e. people that are living with multiple long-term conditions. And frailty just gives us a way into thinking about people who are living with multiple long-term conditions. So the two things run in parallel. So don't think that they're different, because it's the same beast, really. So I'm not sure if I'm going to get the instant voting on this, but we're going to come back to it later on to see if I've changed your mind in any way on care and support planning. But I shall move on to the next slide, which hopefully I can make work. Yes, so to start our story, we're just going to think about the Frailty Paradox, which is this simple thinking that everybody knows that there are people with frailty out there in the system, but the problem is at the moment we don't identify them in any way. And this is just a slide that shows some really simple data that could very readily be misinterpreted by those friends of ours in the Daily Mail to set up yet another NHS scandal, because it shows that people who use intermediate care services, essentially, the majority of them have got long-term conditions. So you're thinking, oh, well, no surprises there. But the little blue arrow just shows you that 23% of these people using intermediate care services do not have a long-term condition. And the Daily Mail would say 23% of older people using community services have nothing wrong with them at all. But of course that's not true. Almost certainly those people, it's not that they haven't got any long-term condition, almost certainly it's that they've got frailty. But they're invisible, because at the moment we don't detect it and we don't code it. So this is our paradox at the moment, and this is what we need to get a handle on if we're going to make progress. So this is how we currently recognise frailty. I'm sorry, there's a little bit of geriatrician speak here with the floff, which is something which I'm extremely familiar with. These are older people found lying on floor. So they ring you up from casualty to say, we've got another floff here. And you can see this lady, Mrs. Greenaway, who's a lady which I've blogged about on the NHS England site, is presenting with three of the so-called frailty syndromes, i.e. that she's had a fall, she's got confusion, new onset confusion, which we call delirium, and now she can't really walk very well. So she's got three of these frailty syndromes, and this is largely the way in which our health and social care system engages with people who've got frailty, i.e. we engage with them when they're at the point of crisis. So what I want to try and do is draw back and try and paint a picture of frailty as a long-term condition, which actually is quite easy to do. And I'm just seeing if I can make this work. But, can't. All right, there we go. So the main thing about frailty to draw your attention to is, as you well know, it doesn't spring up overnight. It just gradually creeps up on people, and perhaps it just creeps up on people so slowly that they don't realise that they're getting frail. And this is one of the reasons why they struggle to really adapt to it. It just creeps up over perhaps 10 or 15 years. So it's this sort of progressive nature of frailty that we don't currently embrace in our system. This is the view of Mrs. Greenaway as she might appear in primary care at the moment. So she's already got 3 or possibly 4 long-term conditions if you count her broken hip with her osteoporosis. And what would happen in a reasonably well-organised primary care practice at the moment is that during the year, probably 4 completely different people, nurse practitioners, would do 4 completely independent reviews of this lady, which would be really protocol driven, and I have to say expertly done, but each piece would be done quite separate from the other, and that in most practices there's not much sharing of these reviews and not much attempt to try and create a holistic care plan at all. So the system at the moment is largely designed to fragment people into different organ systems and different long-term conditions. And as you can see, as I put there, that the issue of frailty is just not addressed at all at the moment. So this is back to Mrs. Greenaway again, just trying to draw back and think about her in a slightly different way. So she's presented acutely with 3 of the frailty syndromes. But if you were to ring up this lady's carer, either her professional carer or her family, they would almost universally say to you these magic words, that she was a fall waiting to happen. And the number of times I've heard that over the years as a geriatrician is just too many to recount, really. So she was a fall waiting to happen. It just throws up this whole idea around, well, why did you wait for it to happen in the first place? Why didn't you jolly well get on with it and try and stop the fall from occurring? But the system at the moment doesn't support that way of thinking. So if we think about frailty in terms of this very simple diagram, we can see, I'm just trying to see if I can make this work. Yeah, we can see there is a dotted line I put on this little scheme diagram here, which shows a person who above that dotted line is independent and below it is dependent. So it's like a switch, an on-off switch. And what happens with frailty, due to the aging process, people gradually lose their inner reserves so that they approach this theoretical line of decompensation, which I'm just showing to you now, and they're living very close to it, just where this red line is here. So when you see these people, the thing to know is that these people appear totally independent, but they have very little inner reserve. You can see there between the red line and the dotted line, very small space. And so along comes the so-called minor illness, which quite typically can be just a change of medication actually, or a bit of dehydration in hot weather, or the urinary tract infection as shown here. And they just fall over the cliff edge, and within 2 hours they just decompensate from being independent to dependent. And so this blue line here just shows where we're picking these people up at the moment. And clearly what we need to do, or ideally what we need to do, is just move backwards and try and pick these people much more upstream. So we could think about trying to pick people up, perhaps like Mrs. Greenaway, a few months before they present acutely, or we could go back a couple of years, or even more exciting, we could go back maybe 5 or 10 years. And I've just drawn these arrows in different sizes to represent the burdens, if you like, the proportion of the over 65 population. So this narrow line here is the people with advanced frailty, who represent about 0.2% of the over 65 population. This is the people with moderate frailty, who represent about 2% of the over 65 population, and this is the big arrow, which is about 22% of the over 65 population. And we could perhaps begin to think about people with severe, moderate and mild frailty having different types of proactive care pushed around them. And the idea is, of course, that what we wish to do, is to try and, plug this resilience gap, trying to get people to be more resilient in themselves, but also think about their local and more general environments, if we can try and get those more resilient. So the first task before us, really, if we're going to do this, is that we need to be able to identify people who've got frailty. Not only do we need to identify them, but we need to code them as having frailty. And these are the 2 approaches that we've been promoting in NHS England. The simple way, which is about empowering people, and then the very simple way, which is about empowering professionals. And I put down there just a reference for you, which was a joint publication by the British Geriatric Society and the Royal College of GPs that came out early this year, which describes these so-called frailty tools, if you want to read about them in more detail. But this is the simple test that we've been promoting, which is just the walking speed test, which simply says that if you put 2 marks on the floor, on the ground, separated by 4 metres, and you time somebody as they pass through the 4 metres. If they take more than 5 seconds or more to walk the 4 metres, it's highly likely, 99% certainty, that they've got the frailty syndrome. And walking slowly predicts disability, long-term care, falls and mortality. Very, very simple test that's highly predictive. With the proviso that some people, of course, walk slowly because they may have one leg, or with an encumbrance, or they may have knee arthritis or have had a stroke. But those people are quite obvious to pick up. So really it's quite a simple test. It's highly sensitive to this abnormal health state of frailty. So to be recommended to you. And then this is the other test that we've been working on and slowly developing and introducing into primary care. This is called the Electronic Frailty Index, EFI for short, and it's based on a very well-established and well-validated model of frailty that's called the Cumulative Deficit Model of Frailty. And that model has been well worked out, and essentially what it means is that the more things you have wrong with you, the more likely you are to be frail, with the proviso that the things that are wrong with you are spread over many different organ systems, so you're looking at the whole person. And those little things that are wrong with you, we can very simply get a handle on by using read codes in primary care electronic healthcare records. So we've constructed a primary care electronic electronic frailty index using read codes. We've got about just over 2,000 read codes that map onto a number of so-called deficit variables. And we validated this tool, and so we know that it does exactly what we want it to do. And these are a list of some of the, this is the list of the deficits that we've included in this model. And if we just take, just as an example, just at random, what should we take? If we take, say, weakness, for example, there would perhaps be 60 or so read codes that would map onto the weakness deficit. So it means that only one of those read codes needs to be in place for weakness to be a deficit for that individual person in the electronic frailty index. So there's masses of redundancy in this tool, which is one of the reasons why it's very robust and works very well. And we're now introducing it into primary care. It's been introduced into System 1 at the moment, so it's now covering about half the English Health Service. There's already interest in extending it to the EMIS web-based system, and it's very simple to do that. The read codes can be released to do that, and we've got lots of interest, as I say, in doing that. And you can see that in this very simple plot here, if you start at time 0, over here, oops, let this work. So if you start at time 0 here, and you follow people through with different healthcare states as determined by their frailty score, you can get different plots. So I'm just showing you the red line here, which is people with severe frailty, over half of whom will be dead in 5 years, unfortunately, compared to the green line, which are fit older people, same age, of course, but fit older people, or very, very few of them will have died over the 5 years. So the green line people, fit people, it's quite appropriate for them to have all the modern intervention type of healthcare that we provide, but we'd be much more cautious about people who have got advanced or severe frailty. And we've had lots of discussions now with my colleague Sean Duffy, who's the MCD for cancer, thinking about using the electronic frailty index to help them select patients more appropriately for things like chemotherapy and radiotherapy. But you can see that also we can select out people who have got mild frailty and have got moderate frailty. And I've put some different possible interventions that we might construct around these different groups of people. And also just to say that what we've had agreement for now is that we can use, there are now 3 read codes that can be used for mild, moderate and severe frailty. And we're hoping to popularise those codes. So anything you can do yourselves to popularise them in your own localities would be very, very valuable. And it looks like there's a lot of interest for the frailty codes to be taken up in the current or the new edition of the Atlas of Variation, which will give us some idea around the use of these codes and the development really of frailty registers in primary care. So I'm just going to move on just quickly now and finish off with just a few possible interventions that might be appropriate for people who've got different states of frailty. And this is the one that we've been developing in NHS England for people who are living with mild frailty. So they won't know they're frail. They'll just be beginning to slow up and perhaps take longer to walk and do the shopping and do practical tasks at home. But we know that there are these key risk factors, which I've shown on this slide here, which are quite easy to modify. But at the moment, the care system will sporadically pick up one or two of these perhaps, but nothing's done very systematically. So we've developed this supported self-management plan, which will be going out to people, I think, next month, which is largely just around, largely encouraging older people with mild frailty themselves to adjust their health behaviour in a way that's consistent with promoting independence in later life. And it's a newspaper, sorry, a magazine type publication we're developing. And I've just got a couple of screenshots of it just to give you a taster of it. So you can see that we're starting off just by suggesting that people do the gait speed test themselves at home, excuse me, which we think is quite simple. And we think will give some buy-in because they may then realise that they are slowing up, and then they'll be able to go through just some very simple things, which nonetheless are quite powerful in terms of enhancing their health and well-being. And there's probably about 10 pages or so of suggestions for them. And then at the end of this document or this guide, we then encourage them to make a brief plan of the things that they think they should be doing. So this is a very light touch approach for supported self-management. It's more like a signposting guide. But for people who've got moderate frailty, we're really thinking it's care planning is likely to be the big way forward. And the problem we've got is that everybody has a different understanding of what we mean by care planning. So this is John Young's view, which fortunately is quite consistent with a lot of other people's. And this is the reason why I gave you that little MCQ at the beginning, because this sort of care planning that I'm talking about at the moment is quite different from the management plans and the crisis plans that currently have the label of a care plan. And there's really quite a fundamental difference between a care plan, which is largely, as I say, for management and crisis management, and care and support planning, which is really a process of care. So one is a noun, the care plan, and the other is care and support planning, the process. And what I've tried to do on this slide here is just show you that the difference between the two, that when you've got a single long-term condition, you absolutely need to have heavily protocolized standard care. But as you accumulate more and more long-term conditions, so the usual protocol-driven method begins to fracture. And increasingly it does become a square peg in a round hole, particularly when people start getting quite advanced long-term conditions singular or long-term conditions plural. So we get to this end of the spectrum with people who are living with multiple long-term conditions and or frailty, when what they absolutely need is a very individualised care package. And that's what care and support planning is designed to do. And the thinking behind this is just gradually evolving at the moment. But it's been supported by the Coalition for Collaborative Care, which is an alliance of many different organisations, and it's based on the successful long-term condition year of care model. And this is the way it's envisaged, that it will give much, much more priority to the person's narrative, their story, and that there will be two consultations that will probably be more conversations and consultations. The first one for information sharing, and then for joint goal setting and action planning. And you can see I've suggested here, and this is something which has been taken up by some CCGs, that they might use the electronic frailty index or simply counting numbers of long-term conditions to move from the current around 2% of the enhanced service to a new locally enhanced service that looks at the 10% group of most vulnerable people that might be suitable for this care and support planning process.
Has joined the conference.
So this is what we might find, back to Mrs. Greenaway, if we were to offer her care and support planning process. It
has left the conference.
It's a very simple process. It just asks people quite open questions. What are the most important things you'd like to discuss today? And I suppose the big surprise for healthcare professionals is actually they don't want to talk about their heart failure or their diabetes. What they want to talk about are the things which are really affecting their quality of life, and I've given you some examples here. And the great thing about care and support planning is that it throws up things like getting out for a chat, which is fundamental to older people living a high-quality life, but is probably not going to be improved by tablets or sort of usual medical models. It needs this approach that's called more than medicine. So you can then begin to think about mobilising perhaps the third sector, the voluntary sector, looking at community assets and resources that would make more of an impact for this lady than simply modifying her medication. So that's all I was going to say, and now we're back to your MCQ again.